Good afternoon. It's my distinct pleasure to welcome all of you to our latest Google Hangout, conducted by the National Cancer Institute's Center for Cancer Research, the National Institute of Mental Health. I am Dr. Marilyn Powell, the Clinical Director of the National Institute of Mental Health and the Deputy Scientific Director. I am the Chief of the Consultation Service for Psychiatry in the Hatfield Clinical Research Center. Today's Google Hangout topic will be the psychosocial impacts on pediatric and adolescent and young adult cancers. We're holding this today on September 1st in honor of the first day of the Childhood Cancer Awareness Month that begins. So now, before we begin, let me remind you all of a couple of things, please. We'd like to encourage you all to interact with our panelists via Twitter, asking questions about the psychosocial impact of cancer on children, young adults, and their families. You can do so by going to Twitter, typing your question, and tagging it with hashtag AskCCR, that's ASKCCR. Second, since we have only an hour and we want to keep the chat focused, we will be discussing only the psychological and social aspects of cancer on children, young adults, caregivers, and family members. Future Hangouts will address other issues. To get started, I'd like to introduce our panelists and have them say a little bit about themselves. First, we have Laurie Weiner, the co-director of Behavioral Health Core and the head of the Psychosocial Support and Research Program at the Pediatric Oncology Branch. Stacy Martin, psychologist in the Pediatric Oncology Branch and Clinical Training Director of the Health Psychology and Neurobehavioral Research Program. And finally, Dr. James L. Clusky, an Associate Member and Director of the Psychological Services at the Cancer Survivorship Division at St. Jude's Children's Research Hospital. Welcome, Drs. Wiener, Martin, and Klosky. Thank you for joining us.
Thanks for having us.
So let's go in this order. Dr. Wiener.
Hello, my name is Laurie Weiner, and I've been here at the National Cancer Institute for 30 years, trained at Memorial Sloan Kettering Cancer Center, and was as committed as I can be to the needs of children and families, and just honored to be here with you today.
Dr. Martin?
I'm Stacy Martin. I'm a psychologist who has been here at the NIH for about 16 years now, and did my postdoctoral and internship training at Children's National Medical Center in Washington, D.C., and worked with children through adolescents and adults with cancer and other chronic illnesses for the last couple of decades.
And Dr. Klosky.
Hi guys, my name is James Klosky, and I'm a clinical psychologist and the Director of Psychological Services and Cancer Survivorship here at St. Jude Children's Research Hospital. I've been here at the hospital for about 17 years. I got my PhD at the University of Memphis. I did my internship at the Children's Hospital of Philadelphia, and then did my postdoctoral fellowship here at St. Jude. I've been working in pediatric oncology for the last 17 years.
Great. So you see we have an expert panel. Before we get to our questions, I'd like to do a brief virtual housekeeping. We welcome your questions related to psychosocial impacts of cancer, but please remember that your posts are public. When posting, please do not post information such as phone numbers, email addresses, or other personal information in the text of your idea or comment. Finally, please keep in mind that this chat is about the topic only. The Center for Cancer Research will be posting a wealth of information during September Childhood Cancer Awareness Month. So let's get started. First question, what is psychosocial care and why is it important when treating pediatric and adolescent and young adult cancer patients?
Children undergoing cancer treatment and their family members experience both short and long-term stresses that can significantly impact their quality of life and their coping. Examples: adhering to complex medical treatment, side effects from treatment, disruptions in their family and daily lives, invasive people and medical procedures, understanding prognosis. And so we provide what we call psychosocial care, which is the art and science of attending to the child's and family's emotional, psychological, social, spiritual needs. What's most important is that the psychosocial care be fully integrated along with the disease-directed treatment.
Thank you. Our second question is, are there standards for psychosocial care? Why would this be important?
Well, I'll be happy to be able to start that and love to be able to hear from other people as well. We know that there's a large body of evidence that documents psychosocial care is critical to the care of a child with cancer and family members. Yet there's significant variability in the psychosocial services that may be provided from one cancer center to another. And while there are standards for any cancer treatment, there hadn't been any standards for psychosocial care per se. And so to address this, a multidisciplinary group of psychosocial professionals inspired by the Maddie Miracle Cancer Foundation, Vicki and Peter Brown, collaborated with a larger interdisciplinary group of experts and stakeholders who used rigorous methods over a 3-year period of time to develop consensus and evidence-based standards that are considered to be essential for the care of a child with cancer and their family members. There are 15 standards, and they describe a minimum level of care that's general enough to be tailored to the individual cancer centers. Examples include routine assessment of a child's and family's healthcare needs from the time of diagnosis through their survivorship, end of life, or bereavement. Making sure that children and family members receive psychosocial interventions throughout the course of the cancer trajectory. Integrating palliative care, attention to the mental health needs of parents and siblings, school reentry. Those are just a few examples. But talking about just survivorship, we know that children with brain tumors and others at high risk for neuropsychological deficit, as a result of their cancer treatment, should be monitored for cognitive late effects during and after treatment. And so one of the standards is that, to be able to monitor a cognitive late effect.
Doctors Clusky or Martin, anything to add?
Yes, so of course the psychosocial standards that Dr. Wiener talked about that was published in December of 2015 in Pediatric Blood and Cancer are really an excellent start for us because we previously did not have those guidelines so well specified. But another resource too that has been around a little bit longer, although it's not specific to psychosocial standards, is the Children's Oncology Group Long-Term Follow-Up Guidelines. So with those, it provides information based on treatment exposures and other types of parameters about certain groups that may most benefit from psychological or neurocognitive assessment. In addition, as part of the COG long-term follow-up guidelines, and we are currently working on version 5 of the guidelines, version 4 is available online, they also have health links. So if there's a specific aspect of survivorship care, including psychological and cognitive functioning, you can click on those links and get more specific information which might be helpful to survivors and their families as well.
And I'll just add to that that the neuropsychological standards of care are really essential to monitoring kids, as Dr. Wiener started to talk about, in terms of repeated brief neuropsychological batteries that we do to monitor their functioning, both to identify the need for accommodations in school and because results can sometimes indicate the possibility of an adverse medical event such as a regrowth of a tumor. And so they also recommend getting supplemental data from parents and teachers about how the child is functioning at home and at school. And these recommendations for interventions that can come out of these comprehensive assessments can ultimately help to improve the child's quality of life.
Great. What are some of the unique challenges that adolescents and young adults face when dealing with cancer or cancer-related illnesses?
I can start on that one. I'll just mention and look forward to hearing others' ideas on this as well, but the developmental trajectory during that transition from adolescence to adulthood is complicated enough without having to be interrupted by a cancer diagnosis. And so during those years, teenagers are starting to establish autonomy from their parents. They're taking on more responsibilities, and they're trying to figure out a sense of identity and personal values. And so when dealing with cancer, or another cancer-related illness in the midst of those milestones, it can be really difficult to have to revert back to, you know, being taken care of by others, like their parents and the medical teams. And so when parents ask me what they can do to make these things easier for their adolescent, I talk to them about trying to maintain some sense of normalcy in their routine. So yes, they now have to go get treatment and take medicine, but what are the things that they still can do? And the sense of identity is so important here, because sometimes people with cancer or another chronic illness feel like that becomes their identity, and they come to see themselves as a cancer patient. But the people around them need to remind them that they're so much more than that. They're also a high school student or a college student, you know, an athlete, an animal lover, a sibling, a son or daughter, a friend. And so it's important to maintain some degree of focus on those other areas so that they can take the perspective of a person with cancer being just one part of who they are.
You know, I think that I would like to add to that as well, particularly with regards to the developmental milestones that you mentioned, that as survivors of childhood cancer move a little bit from being treated more in the hospital setting to going back and reintegrating with their home communities, it seems like that there's different features that survivors talk about having difficulty with based on where they are in terms of their development. So for example, with our folks that are in late adolescence, they might talk particularly about challenges associated with education or with vocational or job outcomes. For those that are a little bit older and that might be married, that they might be talking about difficulties with fertility. For those who are a little bit behind because they've been being treated for leukemia for the last 2.5 years, that if they're behind in terms of dating or forming relationships. So it just seems like that different issues seem to express developmentally based on where that cancer survivor is at that time.
Yeah, and I absolutely agree with everything that's been said, and said so well. So if you imagine friends, you know, being in a hospital setting and your friends are going out on social events or going and meeting new friends or hanging out in sports events or going on college interviews, and here you are spending a lot of time in a medical setting, in a clinic over the watchful eyes of your parents and or your medical providers. It can be very, very isolating. But I have to say there's also growth that could take place during that time as well, you know, and some of these kids are just, I mean, young adults can become very resilient and, you know, develop new skills and new opportunities. It's up to us to be able to help them and their families to be able to do that.
Thanks for pointing out the role for growth in this area as well. Are there ongoing studies that are examining the experience of having cancer or being treated for cancer for the child? Stacy, could you talk to us about pain treatment studies, perhaps?
Sure. I can mention 2 studies that are going on in our group in the pediatric oncology branch to start out with. One is dealing with pain coping. It's using something called acceptance and commitment therapy, or ACT, which is a type of treatment that involves things like mindfulness, like focusing on the present moment and engaging in valued activities. And there's some very impressive research on using ACT to target a variety of psychosocial difficulties, and we're using it primarily to help people with something called neurofibromatosis, which is a cancer predisposition syndrome and chronic pain. We did a pilot study a few years ago where we found improvements in pain severity and decreases in the extent to which pain was interfering in the person's life. And so based on those results, we were able to get funding from an organization called NTAP, which stands for Neurofibromatosis Therapeutics Acceleration Program, to do a larger randomized trial where we're bringing in people with NF and chronic pain, ages 16 to 34. Some are cancer survivors, and they all have tumors that are at risk of becoming malignant, and they all have chronic pain. And we're teaching them ACT-based techniques for essentially how to change their relationship with their pain. And many of them are taking pain medication. They find it's not that helpful, or they've tried various things to get rid of their pain. And the approach that we take is to say, you know, I can't get rid of your pain, and I can't help you control your pain, but I can help get you to a place where your pain doesn't control you anymore. And so that's one that we're really excited about that I'm heading up right now. The second that I'll mention is a study led by Dr. Pam Walters, who's another psychologist and director of our Neurobehavioral research program. And this study is looking at, it's called the PACE study, which stands for Physical Activity for Cognitive Effects. There's research showing that kids treated with radiation for brain tumors often have cognitive declines, as we mentioned earlier, and they're similar to what we see in kids with ADHD. And so there are studies out there on physical activity interventions in kids with ADHD that have shown benefits. So Dr. Walter's study is the first that we're aware of to use a novel home-based physical activity intervention to increase moderate to vigorous physical activity in brain tumor survivors ages 8 to 18. So the kids come to the NIH, they learn about moderate to vigorous physical activity and how to incorporate it into their daily life. They get a fitness monitor so that the kids and we can track their level of activity. And the preliminary findings show improvements in both their activity level and in cognitive functioning post-treatment. So those are a couple of the studies that are ongoing right now that we're excited about.
Great.
Yeah. Here at St. Jude, Children's Research Hospital, we also have a variety of research going on in the psychosocial domains. We're fortunate to be the coordinating center for the Childhood Cancer Survivor Study, which is a very large, well-characterized cohort group that we have here at St. Jude that has been followed longitudinally. That has traditionally been only adults, but we also have another cohort study of survivors here at St. Jude called St. Jude Life. And as a result, those kids are now being enrolled as soon as they're 5 years post-diagnosis and can be as young as 5 years of age. So we're really going to get a chance to look more broadly at many of the effects and ill effects of cancer treatment on child development as they move through to adolescence and young adulthood.
Sounds exciting. Laurie?
Well, you know, we've talked a lot about some of the stresses that children, adolescents, and young adults face. And in a busy clinic day, we don't always know what's going on in the lives of children and adolescents. And so we've developed a distress rating scale called Checking In. And right now we are working on further developing that, doing something we call cognitive interviews. But the goal of that is to be able to have a brief scale, a brief interactive online tool where, again, children, adolescents, and young adults can be able to complete it, and it will generate an immediate report that will go out to their providers so we can make sure that whatever may be distressing them at that time could be addressed. We also know that when a child is diagnosed with cancer, families are greatly impacted, and the first thing is to be able to find out where the child is going to be treated, what they're going to be treated with, but rarely does anyone sit down and talk to the family, at least at that time, about the impact it could have on their relationship, on the parents' relationship, their marriage or partnership. So we have a study that is exploring the time point to the events during the child's treatment when the parents' relationship becomes the most stressed or strengthened, and to be able to find out exactly when to be able to intervene. And from that, we'll be developing an intervention. We also are looking at ways to be able to find the best ways to prepare children for an amputation. We're working on ways to prepare siblings for donation, whether stem cell or bone marrow donation. And then, unfortunately, there are children who are not going to survive. And when treatment is no longer effective, being able to find ways to be able to communicate openly and honestly. Those courageous conversations are difficult. And we've worked over many years looking at this with the National Institutes of Mental Health and have developed a tool, the first advanced care planning guide called Voicing My Choices, which is now available. And has been distributed throughout the world in 4 languages. But we don't know yet whether this is a tool that will help to open up communication with their providers and more so with their family members and their friends. And so we have a study right now that's looking at that, and also to see if it could be useful for older adolescents and young adults. We're looking up to the age of 39. Right now, the feasibility and utility of Voicing My Choices is being examined in other countries as well, including Australia and in Brazil.
I'd like to remind viewers that we would like to interact with you and have you ask questions if possible. Please feel free to tweet us a question about today's topic, psychosocial impact on children with cancer, and tag it with hashtag AskCCR. That's ASKCCR. Here's a question for everyone. what are some resources available to pediatric and adolescent and young adult patients and their loved ones, and where can people get more information about pediatric and adolescent and young adult psychosocial care? Dr. Clusky?
Yeah, I think that there are a variety of different resources, and it's certainly my hope that these survivors, after they've moved outside of their active clinic, are still getting active health care in their home communities. I'm always a fan to work with your primary care provider or with your survivor specialist to see what providers in the home community that they typically work with and that they refer their patients to. Hopefully there's coordinated centers in which that there's already a social worker or maybe a child life worker, a psychologist, even chaplaincy services, many of the different allied health sciences and the professionals that we encounter with all the time. So oftentimes I often say start local and get referrals from your care provider in your home community, but also to look online, whether it's through the COG long-term follow-up guidelines, whether it's through Stupid Cancer, whether it's through all of these different resources so that you can get your specific needs met.
I'm glad that you mentioned COG because they have a wonderful, terrific family handbook that provides families with reliable information about treatment, support, follow-up care. You could also check the NCI website where there's a number of resources that are available for children, families, in different organizations, both for children, adolescents, and young adults.
And I'll just add that, in today's day and age, we have a lot of online resources. There are apps for helping people learn how to use things like relaxation and mindfulness throughout difficult situations. There are some apps for the ACT treatment that I was talking about earlier. The ACT Coach is one that I like. There's also a lot of apps for cognitive and academic tools for helping students who are entering back into school after perhaps having some cognitive effects, helping them organize assignments, keep track of their notes, and so forth. So just searching online on the App Store or seeking out recommendations from people like a psychologist or an occupational therapist can be really helpful.
I also, for me personally, I also feel like that there's some underutilized resources as well. So certainly kind of through the school system that although it may not be cancer specific, that oftentimes our survivors can get support, and even if they transition to college or some type of post-secondary educational program, that they definitely should work with their Office of Student Disabilities or potentially work with the Psychological Services Center or Counseling Center at that university. I also would encourage people to think a little bit more broadly and think about vocational rehab and look at resources through there, whether it's career counseling, whether it's helping to get your GED. There are so many resources out there, but it's just a matter of figuring out what's in your community for you.
Yeah, these are wonderful suggestions. If people feel like they would like to have more in-depth counseling services, the American Psychological, APOS, American Psychosocial Oncology Society, has a help desk which you could be able to call, and they could be able to find a therapist in your particular area.
All right, so we're looking here for some Twitter questions.
Marilyn, something that Dr. Klosky said, which was really very important, and that's that the interdisciplinary nature of people who provide psychosocial care. And you listed many. I mean, there's social workers, psychologists, psychiatrists, child life specialists, chaplains. This isn't a field that is just specific to one discipline. Nursing does a beautiful work as well.
Yes, thank you for recognizing all the people that help, all the therapists, the teachers, everyone in the system. All right, we have a few questions here. The Maddie Miracle Cancer Foundation in Washington, D.C. asks, what should parents expect for a level of psychosocial support from diagnosis through treatment and survivorship? Start, Dr. Wiener?
Well, I think that families should expect for them to have a really good assessment of them as a family, what they've been through before, their understanding of what they have to go through at this time, any special needs that they have in extended family members or other family members, financially where they're at and support that they may need, how the child has coped in the past, any major stresses they've had in the family so far, to make sure they really understand what is going on, what the treatment is like, and how the hospital and the hospital staff can help us to be able to support them. they can get familiarized with the standards that are available and to present those to the staff to see if they could be able to help to be able to learn to advocate for themselves.
Yeah, I'll say advocating for themselves. I'm glad you brought that up because that's really important. Sometimes parents, the whole experience of having your child diagnosed with a life-threatening illness and, all of the medical treatments that are, many of which are not so pleasant, and their child's distress, it can be really overwhelming. And so, encouraging parents to be an advocate and really to speak up and say, I didn't understand what you just said, or, can you go through that again, or what do I do next, what can I expect here, and just ask questions, because there are people available that can answer them. And if you don't get a good enough answer, ask someone else or ask again, and just keep that in mind in terms of being an advocate for your child throughout the whole process and relying on the support that's available.
I like this idea about asking questions and really figuring out kind of how things work in your specific hospital. Hopefully you're getting a good orientation to the psychosocial services at your hospital. Hopefully you're getting a good understanding of, do they use more of a screening model in which every family is screened, and those that present to the hospital with especially high psychosocial needs are getting their needs met first, or does everyone have an initial social worker or some other type of psychosocial professional when they first get there? Figure out, do all of the referrals for psychosocial programming go through your primary care clinic? Do they have to go through your primary oncologist? Or are there other ways in which you can get your need met? Are there parent volunteer groups who also have kids that have been treated with cancer? Really just getting to know early on what the resources are available at your specific hospital will better help you develop expectations of how this should go. And as my colleagues have mentioned, really advocating, asking questions, and doing what you can, not only to get your child's needs met, but your family's needs met as well.
So many families are not aware these services are available, and they're not all available at all centers, but it's important, as you point out, for them to ask if these are available to them. Allie Shoecraft from Charlotte, North Carolina asks, are primary palliative care skills being taught to psychosocial teammates for this population?
I'm sorry, could you repeat that question? Your voice went out there for a moment.
Sure. Are primary palliative care skills being taught to psychosocial teammates for this population? Perhaps, Laurie, with your voicing my choices experience, you might address that.
It varies, thank you, Dr. Powell, it varies tremendously from center to center. There are a lot of opportunities to be able to learn more about palliative care, the importance of early introduction to palliative care concepts, not to wait until a child is seriously ill or close to dying to first introduce palliative care. But that really does vary from center to center. Some centers have palliative care programs integrated, some refer out for palliative care services. I strongly recommend that people get training wherever they can and to be able to work with their team so that early integration takes place whenever possible.
Maddie Miracle Cancer Foundation in Washington, D.C. asks, what can parent advocates do to ensure children with cancer and families have access to psychosocial care?
I think Dr. Martin answered that earlier by saying that really asking for services, really being your own advocate, being able to know what is available or what may be available somewhere else, being able to say this is what I need, or my child needs, or my child's sibling needs, or my parents, grandparents, let's not forget grandparents who suffer tremendously through this experience needs. Finding out what's in the community, talking to your pediatric oncologist, making sure that you meet with the social worker, if there's a psychologist, and find out what resources are available, and to be able to make sure that your needs are met. And schedule ongoing sessions so that you can be able to see, because needs change over time. The way you feel and what you experience at the time of diagnosis is going to be very different than it will be a few months later, or a year later, or 2 years later. Of course, a lot depending on how your child is doing.
I think that's a really important point, and people may think that, oh, we're doing fine, we don't really need any support. But I sometimes encourage people to, why don't you just have a few meetings with your mental health provider here just to maybe learn some coping skills, build up some tools or techniques that you can use when maybe you're not having such a good day. You know, if you have kind of a toolbox of things that you can draw from and just some skills you can practice, then you can have those when they're really necessary.
And developing. Yeah, sorry, go ahead.
You know, it was just to kind of go dovetail that. Also, to create relationships with the psychosocial professionals. Yeah. You know, I'm new to this. It seems like that we're coping pretty well for now, but I sure know where to come in the case that things get more difficult in the future.
You took the words right out of my mouth. Exactly. Those relationships are critically important. So you may get through the first crisis together, you know, fear of needles and helping the child through that, or helping them to be able to swallow pills, or the first financial crisis and being able to access resources. That relationship is so important to be able to establish. I agree completely.
I think Dr. Clusky, St. Jude's has been a big advocate, larger than its own institution, and I wonder if this question is also directed at how do we, you know, this whole month of Children's Cancer Awareness Month is really to advocate across nation and for the diseases that have not been cured yet. Do you have thoughts about that?
Yeah, I mean, you know, I definitely think that in more and more hospitals that there's an integrated kind of clinical and research paradigm and clinical research programs. For those of us that do research in psychosocial care, not only are we charged with helping the patients and family in front of us, but also in terms of disseminating the research that we do by getting more empirically supported interventions, whether it's for depression or anxiety, whether it's different modes of getting those interventions out, whether it's online, in print, whether it's on telephone. I'm really trying to do whatever we can to generalize these great interventions that we have, because we could have cancer survivors in very rural places that may not easily be able to interact with psychosocial professionals. So I think that using this integrated clinical research model and really disseminating the results so that these professionals who may not have much experience in working with survivors of childhood cancer or other cancer survivors in rural communities, at least they have some resources that academically they can turn to. They've got some place to start. And, you know, from time to time, we'll even take telephone calls from those. You know, childhood cancer is not very common. So sometimes after we cure the patient and they move on with their lives and they go to their home community, the medical professional may not have ever interacted with a survivor before and may not be aware of the special tests which the survivor needs as part of their care relative to another 35-year-old. So I think disseminating results, being receptive to calls coming in, and really just getting the word out that these survivors may need additional services as they age up.
Well, so the Maddie Miracle Foundation follow-on question is, do evidence-based psychosocial standards exist? And if so, where and how are they used?
So I think we addressed a little bit of that earlier. They now do exist. How they are used is a question that we're investigating. The American Social Work Society, I don't have the whole name, has a survey that they've looked at recently to be able to see how the standards are being used by social workers. Dr. Ann Kazak at Nemours has a study ongoing right now to be able to look at how standards are being implemented by the view and the voice of the pediatric oncologist, the hospital administrator, as well as the person who oversees the psychosocial programming. So we're learning more about that, but the key is implementation. And the challenges are implementation, and there's a tremendous amount of effort going out right now to be able to help implement them so that every child and family has at least the minimum standards of care to be able to support the child and family through the entire trajectory, whether the child survives or not.
Okay, thank you. Jennifer Strauss from Omaha, Nebraska asks, when a child has cancer, are the divorce rates higher for the parents?
So from my review of the literature, it's very mixed. Some say yes and some say no. Our study, which had 192 parents, so it's not looking at every childhood cancer, parents of every child with cancer, but we found that over half of the parents their relationships have been challenged, but over a quarter have really been strengthened as well. And so I think it's more than the question of divorce and not divorce, it's what happens. What happens to the relationship? What could we be able to do so that the parents could be able to not cope in emotional isolation from one another, so they could recognize each other's needs when they're in crisis and to be able to communicate. We have to remember that these families are often separated for very long periods of time because childhood cancer is often not provided in the home community. And that distance is tremendously stressful for the family, and roles need to change. So it's something that should be approached with the psychosocial team. Support should be provided. We hope to have an intervention soon. But it's an important issue, and it's one that I'm glad that people are even asking about.
You know, I might add on to that response as well, as that, you know, these families have already been created before their child's been diagnosed with cancer. So the quality of the relationship that the parents have kind of coming into the cancer diagnosis is sometimes predictive, as well as how they're going to cope and how they're going to deal with these increased stressors. So the quality of the relationship before the diagnosis of childhood cancer can sometimes also be predictive of how the family is going to cope and how the couple is going to do these added stressors.
And our data has supported that.
Felina Falange from Los Angeles asks, what are you doing for survivors, especially girls left obese by their treatments?
Well, I think one thing that that I talked about earlier is we are looking at the effects of physical activity interventions, and that's being done in multiple centers around the country, including, I think, some studies at St. Jude's as well that Dr. Clusky may wish to comment on. But there's more and more research showing that physical activity has a lot of helpful effects on both the health of cancer survivors and the cognitive well-being of them as well, and it can lead to improvements in quality of life and self-esteem and things like that. So that's one area where we're addressing that.
Yeah, so we currently have a study open here at St. Jude with medulloblastoma survivors, and this is run by Dr. Kiri Ness, in which she has an exercise intervention, and some of the outcomes are the very things that you noted. You know, it's difficult when we talk about obesity. It's complicated by many things. It can be complicated by short stature. It can be complicated by metabolic syndrome. It can also be factored in by different health behaviors, whether it's eating habits or whether it's physical exercise. This is a very important thing, and in addition to the mental health of our patients, with this whole mind-body relationship, we're also interested in the physical health as well. So really creating and understanding all these physical activity can potentially relate to whether it's obesity or whether it's bone health or whether it's cardiovascular fitness. All of these things are really important, but as psychosocial professionals, we're particularly interested in more of the psychological outcomes and how these interventions can affect these survivors.
And again, that speaks to the importance of a multidisciplinary team where we involve, nutritionists and physical therapists and from the mental health side as well, but working together collaboratively is really important for addressing things like that.
Reem Al-Khoja asks, what do you think is the best way to tell a kid that they have cancer and their families?
Did they say how old the child?
No, so I think you might have to address that.
Yeah.
So very much depends on the age of the child. What we really strongly advocate, even for a young child, is that they use words in which they can build on later. So if they're going to say you have a mass, for example, or you have a tumor, or you have, for example, it's words that they can build on. Educating families to be able to help their child to be able to understand what's going on is critically important, but trust is really important too. And sometimes families have said, well, I'm not going to tell them the truth, I'm going to tell them something different. And the problem is that they're going to hear from somebody else the name of what they have, or hear that they have cancer, and the last thing we want is for their relationship to be jeopardized, for the child to ever say, what else don't I know, what else aren't you telling me? So being able to come up with some words they could be able to build on, and so they could say, do you remember when I told you you had a tumor? Well, now that tumor needs to be able to have some medicine to help that tumor get smaller. Or do you remember when I told you you had a tumor and we're going to try to be able to, the medicine to be able to help that tumor get smaller, or that medicine didn't work as well as we wanted it to be. So now, and it's spread to different places, and they could build and build on that. The trust is really important.
Yeah, I think that's important too. One approach that we use here at St. Jude is really to follow the child's lead. So, for example, keep the answers short and developmentally appropriate. The child will ask questions if they want additional information. If the child asks one thing and then the parent and their anxiety unloads all of these medical terms and gives the whole story and the whole trajectory, whoa, like the child may have already lost interest, or they may become really scared, or they may see the intensity of the parent, and that's my cue to be scared myself.
Exactly.
Really, we just try to keep the answers short and in developmentally appropriate language. If the child has a follow-up question, we'll continue to answer that, but we're taking the child's lead on the amount of information that they want, as opposed to just giving them everything on a very adult level, which can be scary and confusing for the kid.
That's excellent advice. And sometimes I'll hear kids spit out most complicated regimens. I don't think they know what it means, but they just will spit out very complicated words.
And it is really important, I think, what Dr. Clusky was saying about working with the parents, helping the parents to notice how their own anxiety or worries might be being conveyed to the child without them even realizing it. So really, working with the parents on what information is appropriate to convey and what words to use, like Dr. Wiener was saying. And, sometimes kids will ask a question and the parents won't know the answer, and it's okay. I tell the parents it's okay to say, I really don't know the answer to that, and maybe the doctors know and maybe they don't, but let's try to find out together and make it a collaborative process between the parent and the child as they both grow through and learn a lot about what the experience is like.
And every child hears information differently. Some are more, more auditory, so they want to just be able to hear a lot of information. Some people like to be able to see things, and they may have some books they could be able to look at. Some children want to just hear it from their parents. Some want to be able to hear it with their doctors there. So really understanding how they understand and hear and how the family communicates. Sometimes there's another person in the family who's not the mom and dad who's been a primary provider, and that's a key person to engage and how much to be able to disclose as well.
And I also just want to add that this is an appropriate referral question. If you're a parent that says, I don't know how to tell my kid, tell the nurse that you're working with, tell the physician, I'd like a little bit of support from one of the psychosocial professionals to talk this out so that I'm prepared before kind of interfacing with my kid. This is an excellent reason to work with your psychosocial professional at the hospital.
And it's not only the child. There's often, what do I tell the brothers and sisters? If I tell them, they're going to spell out the information, or, when do I give them the information? It's not just a diagnosis. It's, if there's complications during treatment, how much to tell. If the treatment isn't working, how much to tell. It's really important.
So you talked mostly about the younger kids, and Allie Shoecraft from Charlotte, North Carolina asks, are there any studies that look at how the impact of cancer in teens and EYA or adolescents and young adults on development can impact them later in life?
Yeah, I think it's important to note, and of course this is very much on a case-by-case basis, but in the grand scheme of things, we actually see that many survivors of child and adolescent and young adult cancers are actually doing relatively well psychologically. Now, to be clear, that's not for everyone. There's certainly subgroups, whether those that are experiencing a lot of pain, maybe those that have experienced relapse. There's certainly subgroups that have functional difficulties or aspects. 95% of survivors of childhood cancer by age 45 are going to have at least one chronic health condition, with 80% of those kind of being life-threatening or very serious. Kind of dealing with those is very difficult. But like we've talked about too, that there are going to be times of particular difficulty, and there could be times that are a little bit better kind of in the cancer trajectory. And no matter what, the thing that we want to make sure is that you know the resources of where to go, so that if you're having particular difficulty, you can work with your psychosocial professional.
And there's data to show that, if when the child is going through the diagnosis and treatment process, that if that is handled in a way that is very sensitive to their emotional needs, and if they get support that they need, and if the communication is open during that time, then it is related to better outcomes long term.
And we also have data to be able to show that adolescents and young adults want to be asked what they need and to be able to be provided services throughout the course of the trajectory, even if they seem to be doing okay on the outside, but definitely ask them, engage them, connect them with others their age. There's some wonderful organizations out there that can help empower them as well.
The Maddie Miracle Cancer Foundation in Washington, D.C. asks, how do you help bereaved families? And how do you help them get support after a child dies?
I think it is an incredibly important question, and one that I think every center addresses, and every bereaved parent could speak to. When you're working at a hospital and your child is being treated at a hospital and you're spending a lot of time at a hospital, the hospital becomes like a pseudo family to you. You get to know the staff really well. And after the child dies, that support that you were receiving on a day-to-day basis is no longer there. So you've lost your child, you lost the support from that network, and you go back home, and your your support networks really couldn't understand what you were going through. They didn't walk in your shoes. They want to be helpful. Many people will have tremendous support if people come out, what could I do? That doesn't last for very long often, and they can feel very much alone. And so it's critically important to be able to have a way to be able to reach out to the bereaved parents, to be able to make sure that they have the support that they need. If it can't be provided at the hospital where they were treated, or they don't want it to be provided at the hospital where they were treated, to find out where that could be. And for some, it may be groups. Other people do not like groups at all. For others, it may be bereavement specialists that they could be able to work with, connecting with different conferences with other bereaved families, knowing how to be able to help other family members who are also bereaved. Again, it's critically important, and I don't think that we do a good enough job.
And I think that that's another reason that we encourage families to really connect with the support network when things are going okay, in the beginning of the process, so that if the child does end up dying at some point down the road, they don't have to start fresh, and they're so overwhelmed and grieving at that time. It's really hard to have the energy to say to yourself, wow, I need to find a therapist. Where can I go look for that? I mean, to not have to go through that, to already have someone that you have a relationship with and that can call on when you need to at that time is really important.
And I also think that on the institutional level, it's really important for hospitals to give staff time to make telephone calls. Those aren't billable hours. They're so important nevertheless. Here at St. Jude, we also have a day of remembrance. So each year we invite families who've had children that have passed away to kind of come back. But I think on the institutional level, and I think that in some cases they're doing great jobs, but we really need to have administrators and leaders at these cancer institutes to really allow these psychosocial and other professionals time in which that they can contact the family, maybe repeatedly if necessary, help coordinate care, and even though that it's not billable, it's very, very valuable nevertheless.
It would be wonderful if it was billable.
Yeah.
Well, Allie Shoecraft asks from North Carolina, how do medical teams ensure psychosocial staff are properly trained and not overworked so they can provide care? Because I know we also have bereavement services for the staff when we lose children that are private to acknowledge the burden of caregivers within the hospital setting.
I think that's going to vary a lot from setting to setting. So, ideally, the medical teams support the psychosocial staff in terms of getting ongoing training that they need, helping them with just, being supportive of their efforts. Psychologists and other mental health professionals in a medical setting, sometimes it can be a little difficult navigating where they fit in, but to have the medical teams support and just convey the message that we think that what you're doing is really important, that goes a long way. So I think that's one thing about that.
The medical team can also support additional, as Dr. Martin said, additional trainings within the hospital setting, or to be able to pay for trainings outside of the setting, to be able to empower them to get a training program so they can get additional staff to be able to help them, to be able to reach out or support part-time staff to be able to support them, but to really look at the caseloads, look at the quality of the care that's being provided, to really do an in-depth look at the services that are provided and really what's missing. And I also say involve stakeholders, involve families, because we just have the perspective of the professional is not sufficient. You really need to engage the families and to see what they feel is being serviced and what they feel is missing.
Okay, Kate Barrett asks Dr. Martin, Within ACT, how do you balance the stressors for the patient within the context of the larger family dynamics?
Oh, that's a good question. So when you talk about ACT, you know, I tend to involve the parents in the process of helping their child. And so, for example, I work with an adolescent who sets some goals for themselves based on the things that they really care about, and then we go through a conversation about how can you reach out to the people that you care about, your parents or your friends, and get them to support you in those goals. And sometimes it's hard because they don't want to burden their families. They feel like they've already burdened them enough with everything related to their illness and care. But to really think about, you know, how you can have that conversation. We might role play it. How can you say to your parent or other supportive person, here's what I'm working on for my self-care, and here's what I would really like for you to do to help me in that effort. So ACT does involve reaching out to the people that you care about to get some help in pursuing your values.
Great. Felina Philan from Los Angeles, California asks, what are you doing to inform all clinicians about the extensive follow-up needs of childhood cancer survivors?
Well, I think that that's multifold. You know, as the number of survivors of childhood cancer really increases exponentially, you know, one mechanism that has been used is to offer CEUs, so these continuing education credits that we all need to maintain our licenses. I've seen more and more that focus a little bit more on cancer survivorship and survivors of childhood cancer. So that's one mechanism that I've seen. Hopefully the institutes that our psychosocial colleagues are working at, that they offer funding to let their professionals go and get this continued education to become more aware of the most contemporary research and ways that they can integrate it into their practice. But that's one concrete way that that I see it being implemented among the professionals I work with.
Thank you. Lastly, Maddie Miracle Cancer Foundation in DC asks, should parent distress also be assessed, and why? If so, how is this done?
So an excellent question as well, and that is one of the standards. And absolutely, a parent's distress needs to be assessed and to be addressed, as Dr. Martin has stated before, and Dr. Clusky as well. You know, when a parent is very stressed, the child's going to pick up on that. It's not just about the diagnosis. Who's not going to be really distressed when they have a child with cancer? But there could be so many other stresses that are going on, or previous coping challenges that's going on. So absolutely, a parent should be assessed for their coping strategies, for their needs, for what it is that they feel like, you know, would support them through this process, and to make sure that those services are provided. And if they can't be provided at the institution where the child is being treated, to be able to get a referral to make sure that they are being treated, because the child is not going to do well when a parent is that stressed and not being able to support them.
Yeah, I mean, for me, this is part of family-centered care, right? We have to consider how the parents are doing, if they've had some type of psychological difficulty, if there's any drug and alcohol problems pre-existing, or if they just need some additional support because their child's gotten a very serious diagnosis. Many institutions are moving towards this family-centered care paradigm, and assessment of parent distress and intervening, whether it's within the institution, whether it's with community partners, that's an essential feature of this brand of care.
I know one of the questions that came up before is about the marriage, but parents can be married and still one of the parents can feel very alone in doing all of the parenting. So we call lone parenting, and we found that's critically important, more so than if a parent is partnered or quote-unquote single. So really talking to parents if they feel like the majority of the burden of the care for their child and their other children and their family falls on them, and to then do what you could do to be able to build in those supports as well.
Okay, we're getting ready to wrap up. Are there questions or final statements you'd like to make about the importance of psychosocial care in the care of children with cancer and their families? Dr. Klosky?
Well, I would just like to say that in general, it is such a privilege for me to get to work with with children that are, and adolescents and young adults that are on active treatment or surviving cancer. You know, our treatments are getting better and better every day. Our survival rates are getting better and better every day. But survivorship sometimes comes at a cost. Hopefully, as part of the cancer experience, that you've had some good experiences with psychosocial professionals, and hopefully that can continue to build well into survivorship so that you're really an expert in learning how to get the care that you need. Hopefully develop some coping strategies so you know how to take care of yourself, but really knowing what you need to do if your mental health heads south a little bit.
Dr. Martin?
I just say that you know, working with kids with cancer, they're so resilient. They really surprise me and the people around them time and time again with how resilient they are, how they maintain a sense of humor during this whole ordeal a lot of times, and just being able to help them maintain that sense of normalcy and keep their identity as someone beyond just a person with cancer is something really rewarding and a good, you know, can make some of that positive growth that Dr. Wiener was talking about earlier, can make that an important part of the focus.
I do want to just say here that although most children with cancer cope fine, there are a percentage of children that do really suffer from serious depression or other psychiatric problems, and that the whole range of mental health care is available to them, and that we all recognize that that might be a stressor that pushes them into a more serious mental health problem, and that that's nothing wrong with them or, you know, a sign of weakness. It's just something that comes along with cancer as well. Dr. Wiener, comments about the importance of psychosocial care.
Well, as the Maddie Miracle Foundation would say, it's not just about the medicine. And, you know, when you do talk to survivors years down the road, they talk about a lot of the social stuff that they went through. They don't repeat the different drugs that they were on. And so I think that we need to be able to remember that. We play a critical role. But really to always remember how honored I am to be a part of the life of families going through cancer treatment. It's being part of this journey with you, if your parents that are listening to this. I thank you for allowing us to do so. And it plays a toll on everybody, but it's a journey that we take with you.
Okay, I think that's about all the time we have today, and I really want to take time to thank Drs. Wiener, Martin, and Klosky for spending time with us. We hope that you enjoyed the Hangout. Shortly, the entire video of this Hangout will be available to you on the National Cancer Institute's YouTube channel. And if we didn't get to your Twitter question today, we will keep it in mind and we will endeavor to get to it in the near future. And we really appreciate your letting us kick off this important day, Children's Cancer Awareness Month, that has came into recognition in the last administration. Thank you.
Thank you. Thank you.
Thank you.
Thank you.